and are so excited to have them with us. And also want to welcome each of you today. It's exciting to see that you've made it out to our luncheon event. I hope you enjoy your lunch, and I hope you enjoy today's panel. I do want to mention just a couple of events that are coming up. We have on December 12th a really wonderful holiday lunch. It's just going to be a networking lunch, extremely nice at Little America. So I hope that you will have put that on your calendars and reserve that time. The other date coming up is January 19th, and we have a connectivity panel that's going to be really fun. Teresa Rivera, right here, Teresa, if you want to stand up. Some of you know Teresa, who leads the UHIN panel and is also chair on a HIE, UHIMSS board, HIE committee. And the other event that you should have on your calendar is April 28th, in which we are going to have our spring conference. It's going to be a little different this year. It's going to be a morning event, very focused, and it's going to be a wonderful event. So keep those events in mind. I do want to now turn the time over to Victoria Hodgkins, who is co-chair of our program committee, has worked very hard with these wonderful CIOs to bring them together, which I don't know how often they get together, but maybe not too often. Apparently they have some things that they share as far as employees now and then that makes it more fun. But anyway, Victoria is just a fantastic person on our board, super, super sharp lady, and we are so fortunate to have her on our program committee, and I'll just turn the time over to her.
Thank you, Julie. I think we're going to turn that one off. I sound pretty loud. Can everybody hear me? Okay. So my name is Victoria Glickman Hodgkins, and it is my privilege and pleasure to act as the moderator for today's panel discussion. Before we dive in, I would like to thank colleagues on the Utah HIMSS Program Committee, Trish Godey, Chair, where's Trish, and Camille Wellard, who I can see at the back of the room, as well as Chase Tichensor, who's standing next to her. And Camille, Chase, and Trish were really instrumental in making today's event happen, so a big thank you for them. The format for our discussion is as follows. I will very briefly introduce Bruk, Mark, and Jim. They will each in order make a short presentation introducing their organization, some of the HIT innovations underway, and also touch on their thoughts about the needs for innovation and healthcare technology at the national level. We then plan to have a very interactive discussion and a good exchange of ideas. So I'll kick that off with a few questions, but then we hope that you will have questions for our panelists. If you do, please raise your hand, and when you're called on, please stand up and just tell us your name and then ask your question. So without further ado, I will introduce our first speaker, who is Bruk Kammerman. Bruk Kammerman began his career in health information technology in 1996 as a systems technician at Rose Medical Center in Denver, Colorado. Bruk quickly discovered his passion for improving patient care through technology. 2 years later, he relocated to Utah and accepted a position at St. Mark's Hospital. Back on? Okay. After serving in numerous capacities at St. Mark's, in 2005, Bruk was appointed as the first Chief Information Officer at HCA's newly formed Mountain Division. As notable as his accomplishments and reputation as a visionary are the warm and lasting relationships he has forged through caring commitment and indefatigable sense of humor. Please join me in welcoming Bruk.
Thank you for that. I feel a bit like a rock star with this on, so I'm really excited. And we're being recorded today, which is really exciting. Normally, I don't allow people to record me because what I say is usually 85% inappropriate. So it makes me just a tiny bit nervous that we're being broadcast throughout the state of Utah and parts of Canada. I made that up. That's not true at all. I am excited to be here, and this is a great opportunity. Mark and I were talking briefly before that we did something similar. It had to be about 8 years ago where we had a CIO panel. I don't think Jim was in his role at the time. But it's always a great opportunity to get together. And I have a great respect for both Mark and Jim and their organizations. and what they accomplish, which is a lot. You know, if you look at healthcare IT and the systems that we support and our work, it's pretty significant. And every year it gets more and more challenging. You know, I think Intermountain's gone through recently some big changes with introductions to Cerner. McKay-D just went live recently. You know, Jim's been through quite a bit with his Epic transition, and you know, I commend them and their organizations for the work that goes on there. You know, every implementation, I always get excited about when there's an implementation that occurs, because every implementation from every other competitor is the worst thing anyone's ever heard. But internally, it's always the best implementation that's ever happened. So it's always sort of you're there laughing, you're like, yeah, that's kind of how it goes. So we, anyway, we've had a lot of work going on in the last few years with meaningful use, ICD-10, that are these sort of big, broad challenges. And doing good in IT is kind of like peeing your pants in a dark suit, you know, like peeing. You get a really nice warm feeling, but no one notices. So it's nice that we can get together and talk about our accomplishments and pat ourselves on the back. That's my only joke, so I hope you enjoyed it. So let's just go ahead and start it a little bit about, I am the warm-up act for the other two, so it's kind of how that goes. But I just want to give a brief overview of the organization. And you know, HCA is the parent company of Mountain Star Health and Mountain Division, and we own and operate 168 hospitals in 20 states and the United Kingdom. And you can see the statistics there with the number of surgery centers, physician clinics. It's broken out geographically into 15 different divisions, and one of those divisions is the Mountain Division, which are hospitals and assets in Utah, Idaho, and Alaska. And so that's sort of the area of my responsibility. You can see the data there. You guys don't get to see it unless you kind of crank your necks up, but it's a really impressive slide that my wife helped me with. So when we talk about, you know, we were asked to talk about innovations, and I don't think there's anything that I'm going to be talking about that's going to be earth-shattering as it relates to innovations, but I do want to tell some stories about some areas where we're really trying to make some strides, and one of those is really improving patient care through telemedicine. In June of this year, there was a gentleman by the name of Ray that lived in Davis County, and he was getting ready for church one Sunday morning, and he experienced some of the symptoms of slurred speech and some discomfort on his right side. His wife was a nurse and thought immediately that this was signs. Took him to Lakeview Hospital, where within minutes it was diagnosed by the ED physician that he needed a consult. Through telemedicine, a board-certified neurologist that appropriately diagnosed him as a stroke patient. They were able to administer TPA, and he was admitted later into the ICU, but saw immediate recovery from some of those early symptoms of stroke. We can now say today that he calls himself a fully recovered stroke patient, and that is all from technology and how it impacts patients. You know, hospitals are struggling right now with getting specialists and subspecialists. The cost is significant, and some of our rural facilities can't necessarily afford that. So through the merits of telemedicine, we're able to provide some pretty cool things. Now, telemedicine isn't new. You know, teleradiology is listed up on the slides that we have here, but we don't even call it teleradiology anymore. We call it radiology. It's just because that's the way we practice business. The last item that I have listed on here is virtual care. I'll tell you another quick story. I was traveling with my family, and we were in Page, Arizona, and woke up in a hotel, and my son, my 10-year-old son, had a red eye that was swollen and had some gunk in it, which was signs of wrong. No, yeah, pink eye. I was kidding. Well, we know this, but you still need a physician and you still need antibiotic drops. So I'm sitting in this hotel room, and so I look up online what to do, and one of the things I read was go ahead and lick his eye with your tongue because the saliva would make the infection go away. Yahoo Answers is really incredible. But there's basically through virtual care, I was able to connect on my phone in less than 5 minutes and have a physician basically doing a FaceTime call with my son, diagnosed it, gave sort of all the instructions he needed, electronically sent the prescription to the pharmacy that was about half a block from the hotel. So we show up at the pharmacy, and the pharmacist says, help me understand this. You're from Utah, your provider's in Illinois, and you electronically sent a prescription to a pharmacy in Page, Arizona. How is this even possible? And he thought it was the coolest thing ever. But that is the power of telemedicine and where we see that going. Wow. Here's my really busy, nerdy slide about big data. And really, we can talk about size and scale and everything else, but one of our key initiatives is improving clinical data, or leveraging clinical data to improve patient care. And, one of the values of the size of HCA's data warehouse is you've got data from 168 hospitals that are feeding information into that regularly. It's large enough that you don't have to wait for patients to come into the system. By filtering the data, you can run models to help drive and improve care. We had one that was related to ICU infections that we partnered with the Harvard Pilgrim Institute, and it was published in the New England Journal of Medicine in, I think it was June of 13, about some protocols that were sort of found through big data and how it has helped sort of prevent some hospital-acquired infections. We've got a lot of work going on right now with sepsis. Sepsis is a big problem in our hospitals, and we're working on some algorithms with this large data set to really improve the earlier detection of sepsis. And I think about this just in the size of the HCA clinical data warehouse. Well, Intermountain's got great clinical data in the university. How awesome would it be if we can start leveraging more than just a single organizations? So the next one is driving innovation through employee engagement. And this might sound like a really odd slide to have in a health IT or innovation meeting, but the reality is 30% of American workers are engaged. And this is from a Gallup study that was conducted. The study went on to say increase in productivity and a 41% quality where your employees are engaged. The other one is significantly reducing turnover. And then it's my belief that when we have engaged employees, we're going to see more and more innovations. And so I kind of put a charge to leaders everywhere to say, let's create that culture that connects to our cause, that connects to the improvement of patient care. Let's invest in our people. Let's just get out of the way and let them do what they need to do. And I think that is a great way for us to sort of lead in innovations. Engaging patients in their care. I think in this community, it's a small enough community that we have, every one of us has family members that go to every hospital system in our community. And I can speak personally, I've had friends and family in all the major systems. And there's one universal complaint from patients is that they feel like they are objects when they are taken care of in our hospitals, that it's no longer a very personal experience. And they feel like they're somehow removed from their care, that the care is happening to them. Technology isn't normally seen as a great unifier of relationships. And we have all these major social media things, but it's not about developing a personal relationship. But I think as it relates to healthcare, we have a tremendous opportunity through technology to really enhance that relationship between providers and patients and improve care in that way. And as we look at pushing forward, these are sort of the 5 pillars that I've sort of listed out here as we get into population health management, where we're getting much better about preventing illness and being in front of it as opposed to waiting until they come and trying to repair it. The wearables, and we can talk about all the different technologies with that, pretty powerful. Interoperability, this is a big buzzword that we're using a lot right now, but it's real, how we connect. I know with Jim and I, with our facilities both being on Epic, there's a tremendous amount of patient information that's shared without us having to do anything. I don't know how else to say that. We get this nice report that shows how many records are exchanged all the time. And this isn't something that we have to go out and really force the providers to do. It's there in the system and it's part of their workflow. I know we're doing some great data sharing with UHIN as well, but if I had a word around interoperability, we're doing it really great within our own organizations. Now let's consider spreading that and doing more. 3D and 4D printing and the possibilities of that as it relates to the industry are pretty phenomenal. And then a smart room and connected care. So I think my time, I was about eight-ish. So thank you very much, and now I'll turn the time over to Mark.
Thank you, Brooke. I'll briefly introduce our next speaker, who is Mark Propst. Mark Propst is the Chief Information Officer and Vice President at Intermountain Healthcare. Additionally, Mark serves on the Federal Healthcare Information Technology Policy Committee, say that fast, which is assisting in developing HIT policy for the U.S. government. Prior to joining Intermountain, he was a partner at both Deloitte Consulting and Ernst & Young, serving healthcare provider and payer organizations. Mark also serves on local boards for the Utah Health Information Network, as well as the Utah Food Bank. Please join me in welcoming Mark.
Well, now the microphone's on, yes? Okay, well, he gets that working. I thought it was actually, well, first of all, I'm not on UHIN's board anymore. I was, so we'll clarify. That must have been an old overview of my background. Yeah, he'll take me back. Well, that's good. But I thought it was kind of cool to sit on the stage between Bruk and Jim. One, it's between a young guy and an old guy. And then secondly, generally when I go to these kind of meetings and stuff, Intermountain's really kind of big, we're big in Utah. And to have HCA right there to my right, I feel like we're a little smaller. Maybe better, not bigger. Anyway, these are good guys. State's in really good hands. I mean, I really enjoy working with them and the things that are happening in the state of Utah. Quickly, this is Intermountain Healthcare. We are pretty large in the state of Utah. We have 23 facilities. One of them we just manage, the other 22 that we own. And then we have clinics throughout the state. We have one hospital in southern Idaho, in Kaja. It's kind of a legacy product that we got when Intermountain Healthcare was formed, when the LDS Church actually turned over 15 hospitals and said, let's start a healthcare organization, and they started Intermountain Healthcare. So we have an insurance company, Select Health, and that's been a very good thing to have in the new market, the things that we're dealing with. And so we really believe we are an integrated healthcare delivery system, and have had being integrated has been incredibly important for us in our ability to provide the care and the things that we've been able to do here in Utah. We have a bit of a legacy around innovation, I think, and this way predates me. And even though I've been there 12 years, I mean, the vast majority of the good stuff happened way before that. And we're living off the legacy of those things. But the first picture is Dr. Homer Warner. Dr. Warner he's the father of medical informatics. He wrote the very first paper on informatics, and he is an inventor. I mean, he invented the HELP information system, and this is back when they were vacuum tubes and large rooms of computers. But he really went through a process of innovating what we needed to do with data and how we could use data to provide better care. And I am so grateful for the work that he did and the people that he trained, some who are in this room, to help carry on that legacy of being innovative around the use of information systems and data moving forward. We're all, I think, primarily IT people. It reminds me of a story of a guy in a hot air balloon, and he's out, doing his hot air ballooning and gets lost, and not quite sure where he is, and so he takes it down to the, lower to the ground, and he sees a guy standing in a field, and he yells down to him, and he says, "Hey, can you tell me where I am?" And the guy in the field says, You're 30 feet above me in a hot air balloon. And the guy in the balloon goes and says, you must be in IT. And the guy on the ground says, well, indeed I am. How did you know? And he said, well, what you told me was technically correct, but it has absolutely no use. Well, the guy on the ground says, well, you must be in business. The guy in the balloon goes, well, yeah, I am. How did you know that? He said, you don't know where you are. You're not sure where you're going. You asked me for help, and now all you want to do is blame me. Feels like being an IT person. We had the Homer Warner Center. Over time, we've created what is one of the largest clinical databases. Now, we don't compare to an HCA or some of the tenants, the big organizations in the world, because we don't have the same population base and the same patient base. But because again, the work that Homer Warner did in saying this data is going to be important, and we ought not just store it as text, but we ought to store it as usable data. We have a large and a very long history of keeping that data, and we're finding it very useful. Actually, Katrina Holzhauser is in here. Her whole job started out in looking at ways to take that data and make it more useful to the industry. But we've been able to do those kind of things. And then recently, we created what's called the Transformation Lab. That's actually about 300 yards from here, right on State Street. If you know where East Coast Subs is, that's kind of how we have to tell people how to get there, because we're right behind East Coast Subs. But it's at this facility where we're really looking at innovative uses of technology across Intermountain Healthcare. And it's kind of a neat little thing that we'll talk just about some of the things that we're doing in that. You know, I like this quote, new models aren't discovered through big data. And I saw a quote today on big data. They said, big data is a ghost. It's everywhere, but nobody can see it. Big data, but are invented through a process of management that starts with hypothesis. Well, again, go back to what Homer Warner taught us and the things that he did. It isn't so much the data or the technology. I mean, we can all create a Hadoop data lake, or we can create large data warehouses that we can assess. It's really the talented people that use it. And you know, most of those people aren't in information systems, frankly. We have to provide ways for them to access it, but these are physicians and nurses and pharmacists and people that can take what they do practically every day and figure out ways to improve healthcare. My boss is a CFO. He's a very unique CFO, but he's the CFO. And he talks about innovation and says, that's healthcare. We all innovate every day. And I think that's important as we think about it at Intermountain Healthcare. We don't have to be the impetus for innovation. We need to be the catalyst that supports it and allows innovation to happen within the clinical areas. Because it's really the smart people outside of IS that are doing the meaningful innovation that's really changing healthcare. This is a picture of the Transformation Lab, part of it. So we have the Healthcare Transformation Lab. And I'll talk about some of the things that we're doing there. We have the Homer Warner Center. So Dr. Warner died, I think, 2 years ago. But prior to his passing, we were able to open up the Homer Warner Center, where we've taken all of our medical informatics team. So the team that kind of is the legacy of Homer. And we brought them together to look at looking at innovation, looking at research and things that we can do to further use data and further improve healthcare through some of the techniques that we have. You can look at some of the other things we have. I think iRise is kind of interesting. iRise is basically a wireframing tool where we can go out and work with our end users and very quickly prototype services, tools that we can build in information systems, create a series of requirements that are very usable, very interactive, and then take those and turn them into code. It's been a very actually good process for us. We're just starting to grow it, but I think it's a really quick way, again, to move innovation out to the people that really are the smart people that understand what to do. We're doing some work in genetics. We had a doctor down in St. George that was very interested in a specific kind of cancer, wanted to, is aligned with getting the DNA and the genetics of an individual, storing it, looking at it, and better diagnosing it. Very quickly, we've now turned that into a business, and that's thriving quite well down in St. George. So another big area of innovation that we're looking at across Intermountain Healthcare. Bruk mentioned telehealth. We kind of started nerdy with telehealth. So we were going to start with I need a doctor, like when you were in Arizona. We wanted to do that here locally, so we started it within information systems. We built the tools. We built all the things, the call center and all the tools that could be used to access a physician. And then we rolled it out to some of our urgent care centers. And this was a very much information systems driven effort. It failed miserably because it was primarily an information systems delivered service. The technology worked awesome, but the organization itself had not caught up to the use of it. Now we're going the other direction, where clinicians are actually driving the decisions around telehealth, and in January we'll be starting a commercial telehealth product, retail telehealth product. We also use it for tele-ICU, telestroke. We have a telegenetics program. We have a whole bunch of Intermountain healthcare products that we're using telehealth for, and I agree with Bruk. It is big time changing for the lives of the people that live in our community. If you do drive down State Street and you look at East Coast Subs, right next to it, you'll usually see that van there. That van we bought to go to HIMSS. And when we decided to stop building our own clinical information systems, which was, well, actually all of our information systems, was about 5 years ago, we said, we're going to go buy PeopleSoft and we'll replace our self-developed financial systems. And we decided to go buy Cerner, partner with Cerner, to replace Help and Help 2, our legacy products that were formed by Homer Warner Center, or Homer Warner. We decided we couldn't and didn't want to give up a lot of the work we were doing around innovation. So we created the Transformation Lab, we created the Homer Warner Center, and we said we need to get engaged more with the industry at large. So every year now we've had a fairly good-sized presence at HIMSS. And it's funny, when people come to that booth, they're like, what are you doing here? You don't sell anything. I said, indeed, we don't sell anything. We're here to collect ideas. We're here to bring excitement around technology and the things technology can do. And it's actually been incredibly successful, the things that we've learned, that we've then been able to bring back and do some of the innovative work that we're doing. A big area around right now in healthcare. So we've got telehealth, we've got portals, we've got mobile, all of us have all these things, but we're creating an environment that isn't seamless for the patient. It's a very difficult interaction for the patient, particularly in an organization as big as Intermountain Healthcare. People don't really want to access this in 10 ways, and they certainly don't want to go to one doctor and get a wearable, to help with their diabetes, and go to another doctor that's post-surgery and get a different wearable that's going to help you ambulate more quickly and heal better. All of those are good, but we're starting to pile things onto our patients and onto our populations. So our digital health strategy that we're developing right now is, how do you weave that together? How do you create an interaction that's through a single mobile device or a single portal that brings all of the relevant information or important information together and make it usable to our patients? This is going to be pretty cool innovation. I think it's something that's going to be important for us as an organization. I mean, think about the other ways we hit them. We hit them from home health. We hit them from our insurance company. We hit them on collections. I mean, there's all these ways we're interacting with our population. We're trying to develop a more singular and single window into our organization digitally, and that's becoming more and more important. So we were asked to talk briefly, and am I over my 8 minutes? I'm fine. That's good. That seldom happens. To talk about nationally, some of the things that could be innovated or worked on nationally to really improve our ability as information technology people in healthcare moving forward. Bruk brought up interoperability. It is really cool what can happen between the University of Utah and the HCA facility, St. Mark's. They can share data seamlessly, but I can't. I can't do it with them because I'm on a different vendor. And there are probably 60 different vendors in the state of Utah where that data cannot move ubiquitously and really help our patients. UHIN's taking some strides to help solve that, but it's still a massive problem. So I would say one of the innovations that needs to happen nationally is we need to get to true interoperability. It's not going to be easy. It's easy to say. I go to these meetings nationally all the time. We have the same conversation over and over. We need to get to standards. We need to solve this problem, and we're not. To me, the big thing that needs to happen around interoperability is leadership. We don't have national leadership around interoperability. If we did, we could solve this problem, and we could solve it very quickly, and it would probably be singularly the greatest thing we could do for healthcare in the United States and the world. It would save billions of dollars and thousands and thousands of lives every year if we had true interoperability. So that would be one innovation. The second innovation I'll touch on very quickly is security. I don't know how many of you are involved deeply with IT, but if you are, you know privacy and security is a massive issue. We spent $40 million last year at Intermountain Healthcare just on IS security and privacy of the data. That is an astounding number. How many surgeries could be given? How much care could be given to people that can't afford that care if we didn't have to spend that $40 million? So an area of innovation needs to be around security. Again, I think what you'll see is a coalescing around a national solution for this. Not the federal government coming out and saying, you have to do this, this, and this, but actually like-minded organizations in healthcare getting together and saying, if we do these simple, these building block things, we can likely improve security, take those costs down, and make it a better environment for our patients. So I'll stop with that, but that's kind of overall what we're doing at Intermountain Healthcare, and now turn it over to the old guy. You get the last word.
Last, but I'll hasten to say not least, is Jim Turnbull. Jim Turnbull's career spans over 30 years in the healthcare industry, split between the Canadian and American health systems. Since March of 2008, he has served as Chief Information Officer of the University of Utah Hospitals and Clinics. Prior to joining UUHC, Jim served for 7 years as Senior Vice President and Chief Information Officer of the Children's Hospital in Denver, Colorado.
Thank you.
Thank you.
I'm on. Okay. Is this a bit loud?
Nice mustache.
It's okay. All right. You know, I never realized how great it is to be on a panel with two guys that are young enough to be your sons. That's great. Except you, Mark.
Thanks, Dad.
You know, it really is. It's really a treat to have great colleagues like these two guys. They've been fantastic to work with and great collaborators. Going to zoom through this. I want to pay a little bit of attention to this first slide. The picture at the top on the lower right-hand corner is the home of the former number 3 rated football team, the Utes. What are we? What are we this week? What are we this week? I didn't even hear. Are we still 13?
10.
10. All right. Yeah. Okay. Top 10. And up on the upper left-hand corner is the Huntsman Cancer Center. In between those two places is probably the biggest innovation incubator in the state. And there are unbelievable resources on that campus. And I want to come back and spend a bit of time on that. The other thing is that funny little thing that looks like an amoeba or something in the right-hand corner. That's kind of a new, it's almost becoming a logo for the healthcare side. And in the center of that are the words advanced health. And that's kind of the new theme that we're actually building our strategies around. And so that's kind of a new look for us. You probably, for those of you that work at the U, you're going to see that a lot more. This is sort of our place, 4 hospitals. So we got 4 hospitals, a bunch of people, and most importantly, we see about 1.4 million patients a year nowadays. So it's a busy place, and those patients are the reason we exist. So anyway, innovation has become this big buzzword, and I've been sort of intrigued by it when you think that people are saying we need to do innovation. And the question I always ask myself is, what do you think we've been doing since 1776? You know, if you look at the Ford Model T.
Well, you know what you were doing in 76.
It's not going to stop, is it? It's just not going to stop. Yeah, that's right. Okay. So anyway, innovation became this big thing. Every magazine, every business magazine you picked up said do innovation. So we decided to do innovation too. And so they said, okay, let's get a bunch of committees together. So we did that. And this is how you innovate by committee. And so typical committee meeting, and not very productive. And the other approach, and particularly in IT, is to go to the CIO and ask them for their input. And Apple asked me a couple of years ago if I had some ideas around the Apple Watch, so I sketched one out for them. And it's got a GPS there in the front, and then the sundial on the left, and I figured that's about enough. But it was rejected because it didn't have a power cord to go with it that they could charge a lot of money for it when you lost it. So that was the end of that. So don't use those two approaches. This is really what you wanted, was a $30,000 diamond-encrusted Apple Watch. So for everybody that's looking for something to buy their husband or their wife or girlfriend for Christmas, this is the must-have. It's only $30K. Come on, you can buy a nice car for that. So I think when we talk about IT innovation at the University of Utah, we need to keep it in perspective. We do IT innovation. The University of Utah does big innovation. Click, there we go. You got Dr. Kopecky, who's Nobel Prize winning research. Pretty big deal when they name a road after you, I guess. The Utah Genome Project. We've got, I think there's over 100 families now that have donated their genomic imprint, and we've got 6.4 petabytes of data parked over in the Center for High Performance Computing. And we've got the big genetic lab up there teasing miracles out of that infrastructure. The virus that causes Ebola was identified at the university, and as you might know, there's now a vaccine for that they're administering basically around the world wherever Ebola shows up to people that come in contact with it. And then the breast cancer biomarkers, of course, were discovered roughly 21 years ago at the University of Utah. That's big stuff. You start looking at that and that impact that kind of stuff has around the world, makes the IT stuff seem a little bit smaller, but that's okay. So there we are. There's the big innovation, the big horse there, and then IT innovation 16 and a half lengths back, but struggling hard to match the other resources on campus. So we do have a gift for. Okay, who can name the horse? Very good. Okay, you get a prize. We'll give it to you in a minute. American Pharoah. Now for the big prize. Which race was it? No. No. Breeders' Cup. There you go. All right. I have a ladies' one for you, Todd. Wear it proudly. Was it Ann that got it? Who got it? Oh, but who said Breeders' Cup? Oh, you got to. Oh, we can't have. Well, okay, you can just decide. There's actually 3 gifts here. You can give them to all of your friends. There you go. Anyway, so only one person. Okay. Poor American Pharoah. All he does is win the Breeders' Cup, and nobody even knows what he looks like. So that's kind of what IT innovation is like, too. And which reminds me, the others, why did you give the secret away about the dark suits? That was... Anyway, let's click. Come on. There we go. So how do we prioritize? We were asked to talk about this a bit. Not very different from the way we prioritize everything else. We've got a governance structure. Ideas come up. They go up through the channels. And most of the big projects get prioritized using our normal structure, which I think is the way IT should be. If it's different from the rest of the business process, probably not a good idea. So pretty standard. The big shift for us and for everybody else is that shift from fee-for-service to value-based reimbursement. So we're putting lots of effort into basically positioning our IT environment so that we can deal with that when we get there. But it seems to me like the bridge between fee-for-service and value-based reimbursement is not getting built very fast in this state. I'm not sure whether we're going to skip it altogether, but Bruk and I were talking about that earlier. It just doesn't seem like the big wave is here, but back east, it's really big. So it'll get here one of these days, but it's not an emergency to get that built. The other thing we're starting to just dabble in is really doing visualization of data. There's, Mark was talking earlier about, data lakes and stuff like that. There's so much data out there. One of our tools that we have is this, in our business intelligence world, we've got a clinical universe that we've built. And the last I heard, it was 250 million lines deep. I don't think you really want to scan through the data. It's much better to look at a picture, so we're starting to work with the Scientific Computing Institute on campus to help tease that out a little bit and get something that's a little bit easier to analyze. Market adoption. There's all these devices that come out all the time. And as they've been introduced, when I look back 30 years, you see these coming out. I still have my Palm Pilot somewhere in here. I hope you're still carrying yours, Todd. You have one? But they get introduced, and it takes a while to be adopted. But let's just look at something simple like the phone. The first commercial phone, who can tell me what kind of a phone that is actually called? There's no old people in here. Crank and holler. You crank the thing, it generates a little bit of electricity, you start talking and hope somebody on the party line answers. That took 35 years from the time of the first commercial phone until it was adopted by 25% of the US population. This lovely device, only $4,000 for the first cell phone. From the time the first cell phone was introduced until 25% of Americans had one, it was 13 years. Smartphone, first smartphone, guess how many years? Until 25% of us had one. 2 years. What's next? A 2-year cycle we cannot keep up with in healthcare. I just don't think that can happen. I don't know what's going to come at us next. So I think our direction is more to wait and see what happens in the market and then adopt it, not jump on it too quick. When did you first see somebody wearing a smartphone? It's not the smartphone, sorry, the Apple Watch. When was the first month this year you saw someone wearing one? Yeah, April, yeah. Yeah, that was, yeah. Todd, he got his in April, yeah. He pre-ordered a year ago, but I had to laugh. I was looking at a news article the other day that I had laying around on my desk, and in May somebody was talking about, it was an article about how hospitals are using the Apple Watch. I think they're writing the news article before it even comes out commercially. And so I think from a positioning point of view, it's kind of like, let's wait, see what happens in the marketplace. In the meantime, we're leveraging what we've got. We have an incredible installed base of applications and infrastructure, and these are the tools that we're trying to leverage to kind of move forward. So these are some of the current innovation projects, but if you look down that right-hand corner, this whole issue around value is something we're really focused on. So we're looking at this, our equation is value equals quality plus service divided by cost. And we're making a big investment on that top line, that quality and service side. So we're looking at several measures for how do we improve quality. And on the service side, we look at our experience in dealing with looking at both not only the day-to-day service, but as you're probably aware, we have an online site that compares our doctors, and it shows their scores, and it also shares all the comments about the doctors. And that has driven our customer experience scores through the roof. So value-driven outcomes is a big thing. Population management is big. Predictive analytics is something we'd really like to get into, especially real-time stuff, but we haven't done a lot there. But the investigation is moving rapidly. And of course, we got Fire app integration out there one of these days. So one of the cool things we're doing, and I'll just whip through this, but we actually, we're using something we call MeVal, where when patients are scheduled, we send them out a brief questionnaire. And before they arrive, they fill that in online. When they show up, we hand them an iPad and they fill the questionnaire in. It's got 7 questions. Average completion time is not 7 seconds. They're very fast readers. 49 seconds. And then that data goes into the data warehouse, gets pumped back into Epic, and they can get a graphical view of how the patient feels about how they're doing, which is probably the most important thing of all. The clinical outcomes are cool, but how's the patient feel about how they're doing? So that's available for the doctor the minute the patient walks into the room. It's currently in orthopedics, but we're going to go across the organization where it's relevant. Buzzworthy devices, just real quick. When this device came out, the Google Glasses, of course, right away, within about 2 weeks, surgeon does surgery wearing Google Glasses. I don't know if he had it on top of his head or where he had it, but they had to publish the article. And of course, Google Glasses are off the market now. The health kit thing, it just hasn't really caught fire yet. Oh, bad. Shouldn't have said fire. Okay. The watch, we talked about that already, so we don't know where that's going. The wearables is kind of interesting because a lot of people, they start wearing them and then they stop later, except for Todd, who wears his all the time. But the implantables, I think that's a real great opportunity. And a lot of them are sort of powered inside, but they're moving towards solar-powered ones. And the cool thing about the solar-powered ones, if you want to power them up, you just go and relax, and you're ready to go again, a couple hours on the beach. Interoperability, I'll wrap this up. The one thing I did want to talk about, the right one with all the wires, the device interoperability is one that scares me to death. And Mark was talking about the security issues. The data is important. The devices really scare me. And we've got to knock off that challenge and make sure that we've got standards. On that note, I just want to say something about Mark. He has been the champion in this state with regard to standards at the national level. And he has carried that message very strong to Washington. And I just want to acknowledge Mark for doing that. And he's a big believer in the standards. And I wish more people would listen to him. I don't like to, but I wish the rest of you would. Okay, so let's have a round of applause for Mark. Thank you, sir. So, good.
Thank you very much. Those were terrific presentations. So I hope people have questions, but while you're formulating them, I thought I would ask one or two. So the first one that occurred to me is, Bruk, you touched briefly on patient engagement and how vital that is to innovation. I wondered if you each would share how you would ideally like your IT team members to prepare for and embrace innovation, because it's change management. Mm-hmm. Who would like to go first?
My son, Mark, he would like to comment first.
Right. I agree with that, actually. Yeah.
So it hasn't been a tremendous challenge to get our employees to engage in innovation. I mean, the real challenge is, what do they do with those innovative ideas? Do we have any kind of structure to take those ideas and do something with them? So again, I just don't think it's a challenge for IT people to want to be innovative. We started small. We started with just innovation within our department. How are we going to get more value, lower costs? So we used a tool called Brainstorm, where we would just collect ideas, and they were very innovative ideas, some incredibly simple. Simple as, if we just change the box that we're storing our tapes in, yes, this is back with tapes, but and we change this out, we could do it in 30 seconds less a box, and we could store them more quickly, and it would save X thousands of dollars a year. And it had varying levels of innovation in that. We've now moved to where Intermountain Healthcare is a partner with a group called HealthBox. HealthBox is an incubator organization, and so we're trying to provide mechanisms where these employees who want to engage in innovation now have an outlet to do that. We're a long ways from being perfect, but to me, it isn't so much how we encourage them or want them to engage in it, because they're innovative. I think IT, it's just kind of second nature to want to be innovative. It's now, how do we take that and do something with it so that they can continue to innovate? If they innovate and nothing happens with it, it kind of shuts down.
Jim, Bruk, would you want to add anything?
Oh, I'd love to get my team to comment on it. We've got a few of them sitting in this room. I guess if I look back over the 8 years I've been at the campus, the big thing on the IT side that surprises me is 8 years ago, I didn't get the sense that the docs and all the medical staff, that they were particularly engaged or that they really cared. and now they are pushing the agenda so hard we cannot keep up with them. And I think just making the data very visible to them has had a big change in their lives. One thing I want to comment on, it's because Dr. Lyons is sitting out here today. And Han is an RN who we were able to convince to work in IT. But I do want to tell you folks about a study Ann did. And you talk about, this is kind of global innovation. We've all done this CPOE stuff across the country, and we've never done really good sort of long-term studies of the pre and post piece. And Ann did one of the most remarkable studies I've ever seen. And I don't want to give you the numbers because this is gonna get published, but it does save lives. And I think that's the most important thing of all. And we now have the evidence that shows that. And contrary to all some of the crazy articles that were written a few years ago, particularly out of Pittsburgh, where they said we were killing babies with CPOE, that's not the case. So innovation is a good thing. EMRs are a good thing. But thank you, Ann.
Yeah, I guess I would add that the key to innovation is ensuring that we're aligning with the patient need. And so, I think IT people love to just sort of think outside of the box and try to envision how cool things might be. I remember working for a boss one time. This is back when I was at St. Mark's Hospital. I shouldn't say that because people might know who it is. But I was working for this gentleman, and we were there really late, and we were solving a problem. And we finished this, and I said, all right, well, we solved this problem. Who do we need to call? He said, well, what do you mean? I said, well, who do we need to call about this to let them know that it's fixed? And he said, well, nobody. I just wanted to see if we could do it. So there was all this time and energy spent on fixing a problem that really wasn't really an issue out there. And I think so IT people, I think, as Mark said, are inherently problem solvers and like to address issues. I think our challenge is getting them with the care providers, getting them with the physicians, getting them with the nurses, and finding out what the challenges are and make it sort of problem focused and then really align the energy. We were in a meeting this morning, and one of them, Jared, is he gone? He's right there. He's innovating right now. We were in a meeting this morning. We were talking about some of the challenges, and he said, gosh, I'd really like to be able to do more and take it to the next level. But I think our plates are pretty full just trying to keep lights on half the time. And so I think as leaders, we have to carve out a way, whether it's a trailer, whether it's a site, some way that we carve out time for employees and manage that with them, that they know that it's okay, it's safe, and we encourage it.
Terrific. I have lots of questions, and I can keep going, but why don't we take one from the audience if someone would like to ask? Trish, actually right behind you. If you spin right around. So if you wouldn't mind standing up and just telling us your name and then asking your question, that would be great.
I'm Kalyani Era, and I work as a senior software architect. My question is, I have seen from all three of you about your future plans and innovations about big data, predictive analytics. Almost every one of you repeated the same things in the list. So can we do something to reduce those efforts or to not duplicate the same efforts across the organizations?
Great, thank you.
I think that our challenge is, you don't want to be duplicating the same things, but we've got to figure out how to consolidate efforts. And I think there are actually a couple examples where HCA and Intermountain worked together on the pre-39-week induction that occurred, and that changed nationally. So there is some evidence of that already, but I think it's a great example of how when we collaborate, it can be significantly better.
Yeah, I would agree. I mean, so it's one of my pet peeves, and it isn't just in this space, it's across the board. There are things going on at HCA and at the University of Utah and Intermountain that are completely redundant and don't have to be. They really, the competitive advantage of it is very minimal. And, should we be competing with people's data and their lives? Absolutely not. So have we figured it out? I don't think so. But, I can tell you, and there's huge cross-pollination between the University of Utah and Intermountain Healthcare, particularly in medical informatics, which a lot of this is learned at. And so there's a lot of sharing at that level. I'll go back to standards and data. Our data is different. And so we're working on a set of data, and our clinicians are working on a set of data, and it is difficult to collaborate at some levels. But when we learn something, we publish it. I mean, 39-week induction protocol, or if it has to do with sepsis or any of the care process models that we're developing at Intermountain, they're getting published and they can be used and shared. But again, because we don't have standards, because our technologies are different, you know, it has to be someone in that organization that takes it, looks at it, and says, okay, I want to replicate it. Because you can't just take it and use it, and that's a darn shame. We are collaborating in security right now, Jim and I, on some issues around security. I just think it makes total sense. So yes, we can do it. We should do it. It has to be forced at some point. We just need to do a better job.
Yeah. I guess I just make a comment that's perhaps a little oblique to that, but there's a lot of research going on around the country in some of the big institutions, and when they come up with some of the some of the guidelines, the rules they're coming out with, there are organizations that are setting themselves up to sell this information to others. And I'm like Mark, I don't think this should be for sale.
Thank you. I think we had a question on this side of the room.
Thank you. Is it? Can you hear me? Okay, hi. Good afternoon. I'm Viet Nguyen. I'm Chief Medical Officer for Lockheed Martin. I've been leading an informal fire special interest group with participants from the university and from Intermountain. And it's been a bit of a slow start because we're educating folks around fire. So what kind of things would you like to see as demonstrations so that you can feel more comfortable that fire, which has recently been adopted for draft standard version 2, that you feel more comfortable about having companies innovate and build applications and tools using fire and having them tested and tried out in your systems?
I can give you a quick answer. Plug it into one of the hospitals in this state or in the country, take that app, move it to another one on a different system, and make it work immediately.
We can do that.
I know you can, Mark. But
I understand what Jim's saying. Technically, you don't have to do anything to convince us of fire. We understand it as a standard. We think it's got really good potential. What do I want to see? I want to see a clinician, a pediatrician at Primary Children's Hospital that wants to use an application from another site, Boston Children's or Children's National or whatever, and we go make it work. I don't. It's a solution. It's to help us with better interoperability. But I think we need the clinical leadership to make it work, and the standard itself works just fine. We can make the technology work.
It goes back to your, I'm just going to yell because this doesn't work, but it goes back to your analogy of when you did telemedicine. When it was IT-led, you didn't get the traction you needed. When the clinicians buy in, now we've got a solution.
Yeah, exactly.
Mm-hmm. Yeah.
Hi, my name's Frank Johnson. I run a company called IWT Health, and we have hospital customers nationally. And we have 6 different products that are in really different parts of the hospital. And every one of my CIO customers, they all have questions about making the ability to interact with the software mobily, right, through the iPad or the phone. And so I get that, and we have a lot of resources dedicated to that. On the flip side, when I ask them about BYOD, how soon do people get to use their smartphone at work? They roll their eyes, they back up their chair, all those good things. So my question for you is, what is your estimate of BYOD in terms of years? Before nurses and other people get to use their smartphone device at work. And if you never see that, what's your alternate?
I would never say never. It's too dynamic of an environment, and there's new tools coming out all the time. And BYOD is less a management issue and our ability to surface apps and things on whatever kind of device. And that doesn't give me discomfort. It's security. And it's a constant paranoia, and it probably is an excessive paranoia and conservative nature around BYOD. If I'm not absolutely confident I can secure it, I can encrypt the data that's on it, I can understand how I'm sharing data with it and manage that device, I'm not going to be comfortable having it in the organization. And it's such it's a defensive posture for sure. But it is a defensive posture I feel like we have to take.
Well, and I'll take maybe a different approach approach on that from a patient perspective is I've met with vendors on the interactive patient systems. I don't want another piece of hardware in the hospital that we're managing. I'd rather have every patient comes in, or the majority of patients come in with a device. So why would we, again, going back to the fear that they have when they come into the hospital, why would we not want them to be comfortable with whatever they have and what they're used to using? And so I think that's where we really push hard and say these vendors that are hardware solutions that cost $1 bazillion, we don't want that. I want a software app that we can put that's managed outside of that environment. I think that's where I would put more energy than sort of the clinician at this point anyway.
You'd asked about sort of, what's the alternative to BYOD, and I've consistently said it's BYOB. So.
Bacon? Is that bacon? It is.
Bake your own bacon. That was it.
I'll take another question from the audience, or I have a few more I'd like to ask. Does someone have a question? Come on. Okay, well, people are thinking of their questions. I'll jump into one of mine. So I was wondering, you talked a little bit about an incubation lab, but where you look for, and I'll use the word inspiration, when you think about innovation, and do you look outside the U.S., do you look outside of healthcare? How do you get those juices flowing, maybe on a personal level, but also on an organizational level?
Wherever good ideas exist. Bruk brought up the 39-week induction protocol. That was not invented in Utah. That was invented on a JAMA article. It was then extended into what we're doing at Intermountain Healthcare. So, but that good idea came from way outside of Utah. And I don't think at least at Intermountain Healthcare, we're not so proud that we have to invent it. I mean, there are a lot of good ideas. So the way we're organized, most of our good ideas clearly are coming from analysts and clinicians and people that have access to a lot more direct information. And so, that's where our inspiration comes from.
You wake up in the morning, I just think you're bombarded with good ideas.
I feel good though, that you wake up in the morning.
I do, especially at my age. But it's just, I just think it's a nonstop barrage out there. But if I had to look at one magazine that I like to pick up if I'm on the airplane, I always grab Wired and read Wired magazine. It's just cool, and they don't spend a lot of time on healthcare, but it's one of those things when you just got a chance to sit for a few hours and think. It's a great input.
That's good, because I'm usually reading Mad magazine.
Yeah, I know.
Bruk, is there any source that you like to use to look
I just
for
read
ideas?
whatever Mark and Jim publish because they're the source of all our inspiration, truly. I think that I don't think there's a shortage of good ideas. I think inspiration comes from everywhere. This is a horrible microphone. So my inspiration is really struggling at the moment. But I think that.
You can just take it off.
Well,
You can just take it off. if
yeah,
you
it's
want.
better. Well, now it's working.
Yeah, there you go.
We did that on purpose.
Okay. Would someone like to ask a question? I think we have time maybe for one or two more. Julie's up front, and she has her hand up.
I noticed, Jim, that you had on your list, and I think the other organizations do as well, but I was wondering if you could spend a few minutes talking about what you're doing in the area of predictive analytics. You mentioned some of the progress, some of the things that are going on with SEP. I know those are core issues from not only a financial perspective, but also from a outcomes perspective.
When did we put the sepsis protocol in? Anne, was it a month ago? Yeah. Is somebody here from the EPIC team that can tell me when the sepsis protocol went in? I mean, things are happening so fast. When I heard the protocol was in, the first thing I heard about it was a doc talking about how he had intervened with a patient because of the protocol. And I was like, oh, we went live? Things are they're just happening so quickly. So some of that, I think the sepsis protocol we borrowed from somebody, and then implemented within our EMR. Our biomedical informatics team on campus, they've got researchers who are working on other protocols, but I think we're in the midst of sort of looking at what's available out in the marketplace. Is this a build, a buy, or a bridge decision right now? We have lots of people who would really like to build protocols, but there's already, as was mentioned earlier, there's already a lot of them out there on the street. Is there a company that has sort of brought all of that together so that we can buy a predictive analytics and population management product? That would be nice, but is that really where we want to go long term? So we're not, believe me, we are not way down the path. The sepsis protocol was probably the first one we really jumped into and that is active.
So I think we are headed down the path. And I don't think is this microphone working? Yeah. And have done some very, thanks. Thank you. And we're all right. We're okay, but thanks, Dad. Sepsis for sure. There's been some really interesting developments around the ED and looking at whether or not a patient should be admitted or sent home. And it's an analytic package that kind of aggregates over the stay of the patient in the ED, looking at what should be the next step for this patient, and that's proven to be very effective. This kind of work is what's happening in the Homer Warner Center. This is the kind where clinicians are aligning with informaticists, looking at the data that we have and looking at things where we can create some of this predictive analytics. And I think to a certain degree some of the hot spotting we do is big time around predictive analytics, what's going to happen in a particular region or area. And so as we're looking at that related to how should we staff? What are we going to do around value-based care and those types of things? So are we way down the road? I don't think so. Do I think we have the right people in place and starting to put the tools together? I actually think we're in a decent position. And then I'll go to what Jim said. I mean, if we can buy it, if this is something someone's thought through and it'll be useful, then that's not a bad way to go at all.
Yeah, HCA's done quite a bit in this space. I've presented a few of those, and I think the value isn't the single organization approach. It's really how do we leverage the strengths between systems. It goes back to interoperability and can we share. I mean, we were talking earlier about some cancer research that occurs. How awesome would that be to have Huntsman and Sarah Cannon and everything that's going on in the cancer space and take all of that data and really start peeling it back and running some models on it to really prevent or find quicker cures or even quicker diagnosis to some of these big challenges that we have. So this is exciting. I think we all talked about it, and we all think there's a tremendous value here. And now there's not a shortage of good ideas necessarily. It's where do we pick, and where do you really leverage the most strength to provide value back to patient care and reducing costs to healthcare in the United States.
Thank you. Well, thank you again for coming. I think we were extremely fortunate to have Bruk, Mark, and Jim agree to this very helpful, interesting, informative panel. So let's give them a round of applause.